Go. So again, welcome to the first official office hours of the Hospice Palliative Spiritual Care Research Network. And we get to feature the Director of Transforming Chaplaincy, who doesn't really need a whole lot of introduction in our chaplaincy world, but George Fitchett. And before we get to George, I'd also just love to do a quick hello to all of you for the sake of George's benefit as well as mine. There's nothing like actually connecting with people. I mean, obviously coffee and sweet rolls would have been the best, but in the absence of that, here we are and would love to do that. So I'm gonna, on my screen, to go with some efficiency reasons, I'm just gonna kind of go clockwise around to do some introductions. Does that sound okay to everybody? So just kind of your name, where you're from, and if you have an idea of kind of where within the hospice palliative world, long-term care, that you might have like a nugget of an idea, and it might just be, hey, I've got this idea for inpatient care, or, you know, I don't have a burning idea, but I'm anxious to see where the networking vibe goes, anything like that. So just name, where you're at, and kind of a little bit about your position, and then just if you have an idea, great. So Chuck, I'm gonna kick it off. You're the first one off to my right here. If you'd say hello to everybody, and George, and go from there.
I will. Chuck Valentine. I am a part of the on-demand spiritual care team for Ascension. The room that you see behind me is in Wisconsin, because I live near Appleton, Wisconsin, and started at St. Elizabeth's Hospital with Ascension, but then moved into this new world. Probably, less hospice palliative care. I'm really working in the virtual chaplaincy arena, but I see overlap for what I'm doing in terms of working with this outpatient population with the principles of palliative care. Primary interests are probably assessment of patient needs and concerns in this outpatient context, and a longer term of spiritual care relationships, and establishing spiritual care pathways, how it is that we determine what it is we want to do moving forward if it's not a one and done meeting with the patient. And Paul, I'll go toe to toe to you any day with Holy Elena jokes.
All right. Well, I appreciate it. Well, some of the language you use there for research is you're talking George Fitchett language there for sure. So I'm going to go to Francisco next. If you would kindly introduce yourself, sir.
Francisco Gomez. I work in Scottsdale, Arizona, and I am the palliative care chaplain here in the hospital. I am one of the first ones to be introduced into the palliative care arena. I don't work with the chaplains. I just work with palliative care, and I think for me, it's been a blessing to be working as a palliative care, and I'm always interested in, learning more about this service that is being offered here in our hospital, is with Honor Health.
Francisco, say the name of the hospital again.
Honor Health.
Honor Health. Okay.
Yeah, and there is 4 different hospitals, and I'm the only one chaplain in one of the locations.
Thank you.
Thank you, Francisco. Hey, John, would you break the ice for us next?
Sure. My name is John Baker. I'm at the University of Rochester Medical Center in Rochester, New York. I'm a third-year resident. Did my first year of residency down at Baptist Health Louisville and was a palliative chaplain there. And then here in Rochester, this is my second year as the primary chaplain at the Wilmot Cancer Center. So I have kind of a palliative, pre-palliative kind of work going on here in Rochester. I work, right now, I'm really interested in narrative medicine, patient illness narrative, and that kind of work. So I've been spending a lot of time on that. One of my supervisors here is Kevin Boyd. So I know that's a familiar name to some folks, but so he's been an influence along that line as well. So.
All right. Hey, thanks so much, John. Abraham, good to see you again. Would you mind going next, sir?
Sure. I'm Abraham Labrada, Santiago. I am in a different Rochester, Minnesota. So I am currently dedicated palliative care chaplain in the inpatient setting, although I'm transitioning to do a 0.5 in the outpatient setting. I'm very interested in seeing not only assessments but interventions in palliative care. We are doing a clinical trial of the spiritual document legacy, Hear My Voice, which you will have Kate soon. So we're doing a trial of 10 patients as a practice, not as a study. So I'm kind of leading that part. And we are going to have, hopefully, other 2 palliative care chaplains who also are going to be here in Rochester. So we have a pretty robust team, and I'm just looking to learn.
Hey, thanks a lot, Abraham. And yeah, I'll make the connection because you're just, well, I'm just up the road from you, I guess, so to speak. So I don't know what to make of the composition of this group, but Christine, I mean, I think I would say most of us would identify as men. And anyway, this is an interesting aggregate. If you would kind of break up the group a little bit.
Sure. Yeah, that was one of the first thing I noticed. Like, was there something I missed in the invitation? My name is Christine Stopka. I am I guess, one-person department chaplain at the Middlesex Health, which has a hospital with 2 annex of ED in the area with the its own cancer center. We have another chaplain who is a hospice chaplain who does a home cares and hospice chaplain only. But I also, because I'm the only chaplain, I am involved in pretty much everything in the hospital related. And one of them happened to be the palliative care. I guess I'm kind of curious to, I guess, see what some of the studies are being done regarding, I guess, how the COVID is impacting palliative care in more detail. One of the things that I think, Paul, you noticed, like my message that I just sent out to the group was about what are some of the ways the chaplains are supporting the palliative care team as they're beginning to see the palliative patients passing away, and then the teams having difficulty with that, especially like there's a lot of sudden death that seems to be happening around this disease, and it's kind of shocking for some people regarding some of these progression. And so I'm just trying to understand more, but also just hear what's going on in the world of palliative care around.
Hey, thanks a lot, Christine. Appreciate it. Chris, you haven't gone yet. I know we talked in the beginning, but formally haven't, right?
My name is Chris Hamm. I am in upstate New York, a little bit east of Rochester, over in Amsterdam. I have been working with the palliative care team here for just about 5 years, mainly with connecting families with their loved ones who are patients. Also, sitting in on family care conferences, and most of my time is spent in ICU. Right now, in and out of rooms where the patients are COVID positive, and that's probably my focus.
Yeah, that's a lot. Thanks a lot, Chris. I appreciate that. Hey, Andrew, would you go next, please?
Yeah, I'm Andrew Tressler, staff chaplain at Roanoke Memorial Hospital in Roanoke, Virginia. And we've got a pretty robust palliative care program in-house, and then an attached hospice through our organization. And part of my focus over the last little bit has been more on an administrative approach with trying to further integrate chaplains into the hospice and palliative world. We've got a full-time chaplain with the hospice team, but not necessarily with the palliative care team. And we've gotten really good feedback from the physicians and the team on the ground. And it's been an interesting journey trying to get administration top down to see the benefit of a full-time chaplain dedicated to that team. So that's kind of been what we've been looking at through our department.
Hey, thanks a lot, Andrew. I appreciate it. And Andrew, I can't remember when you went through Research Literacy 101, but that was, I don't know, a year ago or? Back in
March, right when all the COVID hit.
Cool. Yeah, you're
Yeah.
right. That was about that, but I appreciate you doing that. And if you haven't done that, folks, we'd love to have you be a part of that quick commercial. You can check the website for that. Our next session is in March of this coming year as well. And speaking of partners in this work, I think all of us who identify as palliative care chaplains or cancer chaplains, Steve, you haven't talked yet, have you? Good. Please say hey, if you would.
Hey,
All right.
see me hold up down here in my basement office today. So, live from Peoria, Illinois. Yeah, my name's Steve Drenin. I'm the pastoral care program manager for OSF Healthcare Systems, Hospice and Palliative Care. OSF stands for Order of St. Francis. OSF Healthcare is largely within central Illinois. We do a little bit in Chicago now as of just a year ago. Hospital there as well, but I manage the outpatient setting mostly with 16 chaplains associated in hospice and palliative care in 9 different regions in central Illinois, and then we have 1 outlier region in Upper Peninsula, Michigan, so in Escanaba as well. So we've been honored really to now be one of the testing the validity of the PC7 research sites. So that's going to be coming up. George is aware of that we're involved in that, and with Dirk. So, you know, with all the delays of COVID, that project's been on quite a delay, you know, due to the circumstances that we're all living through with COVID. But now we look to get it up and running pretty soon here to get some patients identified and part of the project for that validity. The other interest I've had and expressed, and again, it's been challenging this year that we've all been going through, is really the best charting practices in identifying spiritual concerns and needs for the system as a whole. We have a very kind of divided up charting practice within pastoral care settings that we've discovered, and we've actually gone through a lot of team building and team contribution to kind of streamline, if you will, the charting practices of pastoral care so that it's effective for all service lines. We have a lot of input from providers of different service lines, most especially in our case, the palliative and hospice side, but then, how's that look toward critical care physicians, ICU physicians, all that too, and what would they like to see in our charting practice as well. So we're hoping that this PC7 participation in this research project will also help benefit that change of our whole charting as a whole, as a whole entity. So it's one thing. We can talk more, but I'm sure it'll all come up. Thank you. I'm really happy to join you all today.
Hey, Steve, thanks so much. I appreciate it. And in the early days of COVID, I too looked like an HVAC service person because that's where I was working out of, was my basement as well. I don't think I had as good as Carhartt sweatshirt as you did, but
yeah, you see all the wires hanging down. And this is my 4th meeting this morning, and this is the first one that I've had to put the camera on. I was been reluctant, so thanks.
Well, that'd be good income.
Ask your mercy.
Well, if you had that skill, you could moonlight. It'd be a nice set of extra dollars too. Hey, Andy, would you want to introduce yourself? Because a lot of people, I know they sometimes see you on the webinars or see a lot of your stuff. Do you want to say hey too, please?
Sure. Hi, it's really delighted to be here. And I told George this morning I was just going to lurk in the background, but it's so great to be able to match up names that I'm sure that I've corresponded with, or some people that I know personally, like Steve and Chuck. So I always get something from being able to just take in all this rich information and knowledge. So it's a real privilege. So I'm glad you all could squeeze in this time, Paul and George. Thanks.
All right, friends. Thanks so much. And then I think we just lost some people here, but I'm glad we're still here. George, I think, has everybody introduced themselves or had a chance to say hello? Great. George, I know you need no introduction perhaps in our chaplaincy world, but if you want to say hello and whatever it is that you want to say before we jump to the next part of this.
Yeah, no, just great to be here. I'm here in Chicago at Rush, and that's the headquarters for Transforming Chaplaincy. So, yeah, Paul, thanks for your leadership. We're really grateful for Paul's hard work, actually, as a convener of the palliative and spiritual care and hospice spiritual care research network. It's really going great, and also your great work, Paul, with the RL Research Literacy Online Course 101. So yeah, great to be here.
Thank you, George. This is a transition point. You're our inaugural group, so I'm so glad you're the first ones to be here. George, is there some place that you want to jump off on with what you heard from our colleagues related to this? I know these are themes, and there's lots of good stuff here to pick from. So I don't know if there's something in the garden that you want to chew on right away.
I just want to do a little bit of networking, actually. Christine, when you said Middlesex, is that Middlesex, New Jersey?
That's Middlesex, Connecticut. Middletown, Connecticut.
Ah, okay. Yeah, good. Yeah. And John, I have to say, I just finished writing a paper with a med student at the University of Rochester. Okay. So she's very interested in palliative care and in spiritual care and palliative care. Her name is Petra Rantanen. I'm happy to connect you with her. Actually, we could do that after this. It was, yeah.
And I first heard about transforming chaplaincy while I was down in Louisville from Kelsey White.
Yeah, sure.
Kelsey down there, and then I was finishing my EDD, and so talking about research and chaplaincy research and such.
Sure. Yeah, great. Yeah, yeah. So palliative care is really a special animal in healthcare, isn't it? I mean, how many years ago did it get created? Right? Is it less than 20 years old, or about 20, 25 years old when the first the term begins to get used? And now we have, right, the specialists, the first kind of specialist training in palliative care. And then, for, right, I mean, that's about 15 years old, right? The first board certification for physicians. I'm not sure about nurses and social workers, probably in the a little bit less than that. And for palliative care, in its core, to say addressing spiritual care, addressing spiritual needs is a core component of palliative care. I mean, it's just like really an incredible decision on the part of the leaders in palliative care to kind of recognize and include that, and then we all know it's in some sense they're exactly the right thing to have done. So then that opens the door for spiritual care providers to be core members of palliative care teams. That's an uphill battle, right? Who was talking about, right? Andrew, kind of, how do you make the case to the team to actually put some dollars there to hire a board certified chaplain, who can become a specialist in palliative care. So it's not all done, but so there's a lot of work. But boy, the kind of reception. Somebody mentioned it earlier, that kind of when you work alongside palliative care physicians and nurses, the kind of, roll up your sleeves, come on, get to work. We're glad to have you on the team. There's no hesitancy about that in most places. It's just, we've got plenty of work here for all of us to do. We need your special contributions. And so how can we do that together? So it's a really, really important area for spiritual care providers, and then for us to do the research to describe what we do, to describe the religious and spiritual needs of the patients and families, and then to begin to describe the impact of the spiritual care on important outcomes. So, that's where the research piece comes in. How do we all work on that together? So Steve mentioned, that, a few years ago, a team of palliative care chaplains here in Chicago said, we need a spiritual assessment tool that's just specific for palliative care. We don't want one size fits all. We want a specific spiritual assessment tool for palliative care because it really is some unique things. So that's where the PC7 came from. So, the team developed it. It kind of grows out of the expertise of that team, but we need to test the validity and reliability of it because it has a quantitative component in which we're kind of quantitatively summarizing the level of unmet spiritual concern in the patients. So when you build that into a tool, then you have to do some further work to be sure that when two chaplains are kind of listening to the same patient, they're going to come up with reasonably similar scores about unmet spiritual need, spiritual concern. So, you know, being able to kind of validate that tool, do that hard work, important work. It's actually not going to be the final work. It's going to be a small scale pilot study. But we're really grateful for Steve and his colleagues at OSF, and there's actually other colleagues in Minnesota at Essentia Health in Duluth who are test sites. We hope there's a possibility Mayo may be able to come on board as one of the test sites. You know, if your institution is interested in collaborating with that, there's a couple of different ways we can institutions can participate in that. So it's important to kind of do the research. But, you know, when we talk to physicians about spiritual assessment based on the PC7, it's like mind-boggling how receptive they are to it. We developed the tool initially in a group of chaplains. We kind of described it to some physician colleagues, but then we did a workshop for physicians at the American Academy of Hospice and Palliative Medicine. And the feedback from the workshop was like, blew me away. It's like physicians saying, oh my God, this is what we were waiting for. We're going to give this to our chaplains. We're going to begin to use it right away. I said, oh, don't use it right away, guys. We haven't finished all the research. But, you know, we just found out, was it 10 days ago, that the article in which we described the PC7 was one of the 10 most read articles in 2020 in the Journal of Palliative Medicine. So, whoa, man, this is a medical journal. There's an article written by chaplains about spiritual assessment. It's one of the 10 most read articles in that journal. Whoa. So, you know, it says to me, in our medical nursing colleagues, they're really eager to kind of partner with us around strengthening the screening and assessment tools that we use, and coming up with the right tools that have a certain kind of focus. So it's really a lot of really important opportunities here. So what are some of the research questions that you all have? What are the research, in addition to this spiritual assessment research, what other research could we do together? We had a hypothesis probably about 4 years ago, that in the ICU, when patients are gravely ill, they're really not going to survive the ICU admission. They're going to die in the ICU, or they're going to be discharged to hospice or palliative care. We had a hypothesis actually that if there is a well-integrated, experienced palliative care or chaplain in the ICU, that chaplain would get to know the family surrogates who are, you know, around this patient who's in the ICU, you know, and they're beginning to hear the news from the ICU staff that, you know, the medical team's not going to be able to do much to kind of improve the patient's status here. And the family's beginning to absorb that. Right? And what does that mean for care for a loved one? You know, they may or may not have recognized that the end was near. And, you know, they actually have to join with the MICU team to make some difficult decisions about discontinuing aggressive care, allowing natural death, discharging to hospice, things like that. Families, you know, most of the time, those ICU families have never made that decision before. They don't know how to do that. They may be ready for it. They, you know, a lot of them are not ready for it. So we had this hypothesis that actually if there was a chaplain who was working intentionally with those ICU families, that the chaplain would help the family absorb that difficult news sooner, help them process it a little bit sooner, and actually help them come to a recognition that kind of comfort care was really a loving and faithful thing to do. That would help them recognize that sooner. And that as a consequence, actually, those patients would not linger in the ICU so long. There would actually be a shorter length of stay before death, which a lot of our healthcare colleagues and administrators would recognize as actually an important conservation of resources. So we wanted to know whether or not that hypothesis was true. So we recruited colleagues from 4 different medical centers. Rush was one of them. IU Health in Indiana was another one. Beth Israel Deaconess in Boston was the 3rd, and the 4th was St. Thomas in the Ascension Health System in Nashville. And we did a retrospective chart review of any patient who had been admitted to ICU and died in the ICU, medical ICU, over a 3-month period of time in those four hospitals. And we then looked at all the chaplain chart notes. We looked at all the medical information about those patients. We looked at all the chaplain chart notes. Who had a chaplain visit, who didn't? About 70% of the patients had a chaplain visit, but about 30% had no chaplain visit. And then we looked at whether or not, what were the chaplains doing, and then what was the impact of chaplain care on length of stay. And we found out that the chaplains were mostly doing a lot of emotional spiritual support, and they were very rarely in family meetings where families had to make hard decisions. Of the 250 patients, there were 400 total chaplain visits, and of those 400 total chaplain visits, about 15% of those visits, chaplains were involved in helping families with decisions, talking through decisions, helping family members connect with the team, helping family members share differences of opinion, come to consensus with each other. So of these patients, right, of the 400 chaplain visits, only 15% had any focus on decision making. So we've begun to think, actually, that's probably not good pastoral care for those, spiritual care for those families, that chaplains need to be more intentional. Not only we don't want to have less spiritual emotional support, but we actually think there's space for chaplains to be more intentional. I just had a conversation with Shelley Varner Perez, who's one of the Transforming Chaplaincy Fellows, who's at IU Health. And in another project, it's actually around NICU patients, chaplains are beginning to be thought of as decisional coaches. I'd never heard that phrase before. I think we do a lot of that in the ICUs, listening to families, helping them. What if we're more intentional about that? So, a lot of palliative care patients are not in the ICU. They're getting outpatient care, or they're getting other kinds of care. So this is a small part of what palliative care teams are doing, is those ICU cases. But it feels like there may be space for us to be more intentional about being decision coaches, as well as providing spiritual emotional support. I bet a lot of that, right, Christine, you were talking about the COVID. I bet a lot of that is happening around COVID, right? The teams are having to decide which patients they can continue aggressive care with. The families are having to absorb that news. To what extent are chaplains helping with that? So that, just back to the ICU study. So when we looked at whether or not chaplain care was associated with shorter ICU length of stay, it turned out not at all, actually, in part because the chaplains, the patients who had extended ICU stays got more chaplain care. So that's technically called reverse causation. If you're in the hospital longer, if you're in the ICU longer, you're more likely to get more chaplain care. So but we did look at whether or not, if you had a chaplain visit in the first I think it was 48 hours of the admission. Was that associated with a shorter length of stay in the ICU? And it was. It wasn't statistically significant. It was too small, but there was a trend in that direction. So we think that if chaplains are more intentional about being decision coaches for those patients at near the end of life in the ICU, that there may be more support for those families who have to make difficult decisions, and that those families will experience less emotional distress around those decisions, and that those patients may actually have a shorter length of stay in the ICU before they die. And that will be a very important finding for our healthcare colleagues. So down the road, we hope to actually do a project that will look at that. But anyway, what do you think about that? What other kinds of stuff do you want to talk about today?
I'm kind of curious because one of the things that I just remember our hospital is doing right now is having a rehab center for people who survived COVID. So it seems like there's a possibility of work needed for palliative care for those who survived COVID, because you don't come back 100% when you have gone through the severe COVID experience, that there is a deficit that people are dealing with, and we don't know what that means, but it looks like there's a possibility of palliative work that's needed in that field. What's interesting is that, I don't know because we only have one chaplain, but I was not invited to be part of that program in any level. And I think one of the challenges that often I find a lot of chaplains feeling overwhelmed with the need versus how many chaplains are available to fill those needs.
Yeah, Christine, that's an incredible challenge. You know, one person department, oh my gosh, right? I once heard a chaplain in a similar situation say that the best strategy is actually not to try to fill all the needs, but to document the unmet need. And to be able to describe to your healthcare colleagues, you know, because there's only one chaplain here, these are all the needs that we couldn't get to. And these are the implications of those needs. You know, a quality of life was worse, that spiritual emotional distress was unaddressed, that important rituals and support may not have taken place for patients and families, and certainly important support for staff who are overwhelmed was not optimal. You know, try to help the organization understand that it's not realistic for one person to be doing all those things, and to spend some time trying to gather data about what isn't getting done because we're not staffed at a realistic level. But another way, I mean, to think about gathering data, so there's a number of places that are thinking about creating COVID clinics, right, for patients who have symptoms long term. And will those clinics actually include a quick measure of religious or spiritual distress in those patients? So we know in other clinical populations, palliative care patients and cancer patients, that somewhere between 20 and 60% may actually be experiencing religious and spiritual distress. And there's a variety of different ways to measure it. You can measure with 2 questions, you can measure it with 6 questions. And so will the team be willing to actually include a measure of religious and spiritual distress that would allow you then to describe, you know, that among these long-term COVID patients, you know, 30%, 40% are describing apparently experiencing religious and spiritual distress. And so can we, you know, refer those patients to a chaplain who could do an in-depth spiritual assessment to see whether or not there really is distress, because the screening is not a guarantee that there's distress, it's just a preliminary indication. And then for those for whom there is actually, based on the spiritual assessment, evidence of religious spiritual distress, can they receive ongoing spiritual care. So that's kind of what Chuck and his colleagues are doing in Ascension with their on-demand care. Is they're taking patients who are, in Chuck's case, they're patients at home, who are patients with multiple chronic conditions, and they're being screened for religious spiritual distress. And based on that, then they're getting an in-depth spiritual assessment. And then based on the assessment, they're getting virtual spiritual care by phone. But that, that takes the whole issue of documenting religious spiritual distress from the kind of anecdotal level where the chaplain or the nurse or the doctor says, well, we think about, 1 out of 3 of these patients have religious or spiritual distress. It takes it from the anecdotal level to actually the kind of documented level. And we can talk about best practices and screening tools. What are the 2 or 3 questions that could be asked?
Actually, I think that would be very helpful. That seems like a really good tool I can use pretty much throughout the hospital. Since
Yes.
we don't have tracking available, it'd be a great tool to give to the social worker and nurses to use to do the screening that will bring the referrals, which will also indicate the need. Because right now, the consults are not coming in, so people think that there's no need. But I feel like I'm missing a lot of the needs that was present, but didn't get to. And how chaplain involvement actually could have minimized some of the really difficult situations, especially with the visitation rights. There is a case where a couple, elderly couple, been together for like 60 some odd years, didn't have any children of their own, adopted one who got estranged. And the husband couldn't come and visit the patient. And patient coded. And here we knew she was not going to provide. They have to do a CPR. And literally she was almost declared, and somehow she came back before the doctor declared officially. And they were like looking at her and trying to figure out what to do. And I'm like, is anybody going to call the husband to come in? I know there's no visitation, but we know where this is going, but you're not going to call the husband in. And they really, like, that prompted to have the compassionate visit, where after compassionate visit, when the husband left, patient died. And the whole time the husband could not get around to reality of what was happening or even accept the fact. So he was sharing hope that he might see her when she gains consciousness. And all I could do is just kind of encourage him to just stay with her through that time and be there for him as a support. And when I called back the next day after the patient passed, he expressed less of emotional distress, feeling like there was a closure in some level.
Oh yeah, you could imagine how awful it would be for him if he hadn't been able to come in. Yeah. And COVID's doing that all over, isn't it? Right. I mean, so we just don't know. I mean, that's another question. Actually, is how much really painful grief is happening, unresolved grief is happening in family members who lose a loved one from COVID or from some other illness because it wasn't well cared for because of overwhelming. So, and to what extent do spiritual care departments need to kind of think about developing COVID-related grief support, virtual grief support groups for loved ones. I've heard of the groups like that in congregations. I haven't heard of them in spiritual care departments, but it feels like, whoa, that's a winner, right? I mean, it's just got to be a lot of people who are experiencing a lot of pain that couldn't be there when their loved one died. They couldn't, all of it, we know of what's important to that. The funeral wasn't what they usually would have. So the kind of normal processes and support that people would get in loss have all been disrupted. And so what does that mean in terms of unaddressed grief? So, what would it mean to kind of have a grief support group, virtual grief support group for some of those families? I think we need some people to try it, test it out, see what happens, see what the need is, see what the response is, see what works, what doesn't work. And if in fact it turns out there's a big need and that virtual grief support groups can be important, then I think, then we need to get ourselves organized to do that.
And our hospital system is actually just beginning to put that together, something very similar to that. We just had a new grief council, I guess is what they're calling it, convene, and spiritual care, art therapy, kind of these different modalities throughout the system are kind of coming together because we're starting to see the need for families outside of the hospital. Once a family member dies of COVID specifically, it's different support in the midst of the pandemic than what we've ever seen before. And a research question that I guess I have, I, in preparation for this, talked with some of our physicians, and we just had a new resident within our peds department come on to that service line, and he's got a pretty good passion for palliative medicine for pediatrics. And for the assessment tool that you all are developing, do you think that's going to be easily adaptable for the pediatric world? I know it's very different needs for both the patient side and families dealing with moms and dads and grandparents, and just the dynamics of losing a pediatric patient is just different, not more or less, just very different than an adult. I just wonder what your thoughts are with adapting that tool or something similar.
Yeah, thanks, Andrew. So that when we developed the PC7, we actually had to say, look, palliative care is really pretty. So part of what we were doing was we were moving from one size fits all assessments that would be good across the whole hospital. You know, it would be good in behavioral health, it would be good in pediatrics, it would be good in the ICU, it would be good in palliative care. You know, so spiritual aim, for example, or the 7x7, you know, are these kind of one size fits all spiritual assessments. And we kind of said, look, no, that's actually, the days for the one size fits all spiritual assessment are kind of over. We need to develop condition-specific spiritual assessments, because the spiritual needs, we know enough to know that the spiritual needs for different clinical populations are not the same. And so we can be more efficient in the spiritual assessment if it's condition-specific. So then we said, okay, so we're going to do one for palliative care. And we began thinking about that and said, well, is it an assessment of the patient, or is it an assessment of the family, or is it an assessment of both? And is it an assessment of patients who are receiving early palliative care around symptom management, or is it an assessment about patients who are near the end of life who are receiving palliative care? So the team made some decisions that we were actually just assessing the patient. We were not assessing the family, and we were not assessing all palliative care. We were really assessing palliative care near the end of life. So that means that I'm not sure if we said it, but we certainly assumed it, and that it was, so we were talking about palliative care for adults. We weren't talking about palliative care for children. So nobody on that team actually had any expertise in care for palliative care for children. So we didn't even try to crack that nut. I think the issues, you know, as far as I know them around palliative care for children, are so different that our model could not be easily adapted. And so the way the PC7 was created is that there were, I think, 7 palliative care chaplains in Chicago who were working together on another project. It was the Coleman project in an earlier version. Abraham's involved in the Coleman project in a different version now. But the group actually met for 2 years. So we actually had, you know, phone calls for once a month for 2 years, where we were talking about the issues in adult palliative care at the end of life. And then we created the model based on that. So, you know, I think what we need in pediatric palliative care is we need an experienced group of pediatric palliative care chaplains to come together and talk about the strengths and weaknesses of the adult model and what needs to be revised for a pediatric model, and then to test it. So part of how we tested the PC7 is that the chaplains took turns bringing cases, and once a month they would give us a case, and we would all score the case and assess the case. And then we would discuss it on a phone call. And based on the early discussions, we we sorted out the model. Some things we included, some things we threw out. Chuck is doing something similar for the on-demand patients with multiple chronic conditions, and their team developing a somewhat similar version there. So I think that's what we need in pediatric palliative care. I think it'd be easy, you know, for people who are interested in that in the palliative care network to partner. You know, Transforming Chaplaincy has a PEDS network, to find partners in the PEDS network who would want to do that and develop a version for PEDS. But so that would be the way we would, I would recommend doing that. And, you know, we have a number of strong partners in PEDS chaplaincy, you know, Cincinnati Children's, Akron Children's, Children's Hospital of LA, Boston Children's, Children's Hospital of Philly. So there's, you know, it would be easy for us to find partners who could do that work together. I don't know if that helps, Andrew.
Yeah, George, the thing that spins in my mind as you were talking about it is it's pretty clear that this assessment can't be one size fits all, because the context will change so much. The question is there a basic frame so that you don't have to begin ex nihilo with every successive population? Can you say that, you know, these are the global areas of assessment that we would want to be able to address, understanding that they're more prominent in some populations, less prominent in others?
I don't know the answer to that. So, you know, I think around end of life, you know, whether or not it's adult or children, there may be some similarities. But then when I think about behavioral health, and I think about, you know, spiritual care for people with addiction, spiritual care for people with affective disorders, spiritual care for people with major psychiatric illness. Boy, I'm not sure if the major themes for them are the same. I'd want to get a team together, let them do it, and then compare it. So I wouldn't begin with the assumption that the major themes are the same. I'd actually begin by asking the team to kind of, who has the expertise in that area, to kind of come up with what are the major themes that you see? What are the major spiritual issues you see in your population? And then when we have it done at that ground up level, you know, in a bunch of different clinical populations, then we'll put them all up on the whiteboard together and say, oh my God, there are 3 themes that are the same in all these. But I wouldn't begin with that assumption. That's what it means to be an empirical guy.
Yeah, I'm not sure I'm saying begin with, but have something to have in dialogue with, so that you know you're not missing large areas because of what's commanding your focus. Take it back to where you started with this notion of decisional coaches. The thing that struck me with that is, I think there are 2 things that are really important for that relationship. One is that it's an empathetic relationship, and the other is that it's trusted. Question is, do we have any data that suggests how it is that empathetic and trusted relationships are built? How long it takes? What are the characteristics of them? What is done by the practitioner so that the patient sees them as empathetic and trusted?
You know, it's not an area I've worked in, but I believe there actually is data about that, about both things. I think there's probably variation in what it takes to develop trust. That there may be some situations where trust can develop quickly enough to make decisions, and other situations where it takes a lot more time. but it's an interesting issue, right? So, I mean, one of the issues that, we've all become conscious of is actually the impact of systemic racism in our society. So there's a lot of impact about that in healthcare. We've become very conscious about that. So, a number of people have begun to say, do we need to match the race of the chaplain to the race of the patient and family in order for spiritual care to be effective? We actually don't know the answer to that. In what situations, for what patients and families, does the race of the chaplain, it's actually irrelevant, or the religious affiliation of the chaplain is irrelevant, or the gender is irrelevant, and in what situations is it actually extremely important? And so it's possible to do research about that. Other clinical professions have done some research about that, and they get mixed results. It's actually a complex topic. But when you talk about trust, it's really a great question, actually. What are the situations where trust seems to develop quickly? So some of you know that I'm interested in case studies, right? And with my colleague Steve Nolan, we've published 2 books of chaplain case studies, but then our colleagues here in Chicago have actually published a 3rd book of chaplain case studies that came out about 10 months ago. So Jeannie Wirpsa, W-I-R-P-S-A, is one of the editors, and Karen Pugliese is the other editor. And all of the there's 9 case studies in that book. All of the case studies are about chaplains helping with decision making. And Paul has a case in the book, actually. But one of the cases I like to refer to in that book comes from Michelle Kirby in San Diego at the VA. I'm not sure, this was a case when she may have still been in training and may not have taken place at the VA, but she's the on-call chaplain. And it's the middle of the night, and it's an African-American family. The matriarch has a massive stroke, and she's brought to the emergency department and intubated. And I can't remember if the case, she gets moved up to the ICU or whether or not the case is happening in the emergency department. And she gets called, and she meets this family. So here's this white liberal Protestant chaplain meeting this African-American family, who are very religious, are Protestant, and she gets to know them, and discovers that their mother would never want to be kept alive on machines. And the team's about to kind of, keep her going there. And so the chaplain, bridges the communication between the family and the team, helps them talk this through. And they all realize actually that comfort care is what they want. And it all happens in a matter of hours. And how did Michelle develop the trust for that family to trust her to help them make that decision and bridge that communication with the physician? You can read the case and look at it, right? and then there is a bunch of interesting research about empathy, so we can talk about that. But while I'm talking about that, the other new article that has just come out, it was in the Journal of Healthcare Chaplaincy, and for those of you who are members of Association of Professional Chaplains, the articles in that journal are available to you. And it was published by Judy Ragsdale, who's a spiritual care manager at Cincinnati Children's and a CPE educator. And her co-author was Kate Desjardins, who's she's the convener for the Transforming Chaplaincy Pediatric Network. And the article is about a new model for chaplaincy. So how many of you have ever read an article that is a model for chaplaincy? A theory, and actually, I'm sorry, it's not a model, it's a theory. And it's called the religious, I'm forgetting it. It'll take me a minute to find it. It's the religiously focused, relationally sophisticated, I'm getting it wrong. Chaplaincy theory. Thank you. Who said that? Who's read it?
Steve.
I'm sorry, who's me?
Steve.
Steve, yeah, there you go. Is it religiously informed, relationally skillful chaplaincy theory, right? So part of what they're saying, Chuck, is that, of course, we assume that the empathic connection is an essential part of chaplaincy care. But it's not the end of chaplaincy care. Some very important things happen because of the empathic connection, the relationally skillful part of what we do. But then, you know, that we then take that relationally skillful empathic relationship that we've created with patients and families, and we help them in a variety of different ways. And decision coaching is not the only way, but it's one of the ways. So, and part of what Judy and Kate were doing in publishing that was in some sense saying, okay, here's our theory. It's based on some experience, and they describe the experience. And then they say, okay, now as a field, let's test it. What will it take to test? What will it take to do the research to test this theory? So it's a really kind of exciting development in chaplaincy, modern chaplaincy practice, to have a kind of theory and to think about doing research to test the theory to see if it's right. And we will do a webinar based on this probably in March. So, you know, if you're getting the Transforming Chaplaincy newsletter, keep your eyes open for the date for that newsletter. Paul, I'm chattering on and
That's
using up the time. And
that's what we asked you to do. I'll have some parting comments, but George, if you have any parting thoughts, or if any of you have that one last question you want to get to George. Thank you, Chuck, for what's in the chat. Anybody else have anything? I will say then, Steve and Abraham, I'd love to talk to you guys down the road, and George, to float an idea, but I don't think anybody's ever tested, like if we have chaplains in the outpatient setting and comparing that to a group where that's not, because they're looking at all sorts of like, are people readmitted? Those kinds of things, like the people that never ever show up. That would be fascinating, especially like George, you were saying around decision-making. That would be a lot of fun to see some results come out of that. Especially now that there are more chaplains in that outpatient world.
Agree wholeheartedly. We got some metrics on that already. It's a big thing.
You do? Fantastic.
It's pretty big. 30-day readmission rates and stuff. And then I had some chaplains keep some side tabs if they had decision-making conversations, and then, rate related to the 30-day readmission rate. That affected that. It's very, very, very preliminary, and it's more on the side, but man, it's fertile ground. I agree with you.
Yeah, let's talk. Yeah, let's crunch some numbers. That'd be really interesting.
Steve and his colleagues have great numbers, man. We got to help get some of that published.
Yeah, but we need help. So pray for us.
Yeah,
we'll get there.
We're here to help you, man. We're here to help you. We're going to be your partners.
Anyway, you talked about that. That was something I've kind of been curious about. So I appreciate this for the connecting who we are as colleagues kind of reasons, kicking the can around the conversation around here a little bit. And obviously, George, to hear of your expertise and how you've led us in this field for many years and continue to do so. And so thankful for that. Can I just say, George, before you get a final thing, folks, please, I'm all about research evangelism. Invite others to join our network. So if you have research or palliative care, hospice chaplain colleagues, as chaplains and your members, we're growing slowly, but social workers, nurses, physicians, hardcore researchers, we want them, bring them on. So it's really, you just go to the site for our network, you hit invite, you get a link, you send it to them and tell them not to do the request to join function. Otherwise, they get kind of stuck in this longer loop. Anyway, thanks, George. You get the last word.
Oh, yeah, no, great to meet you all, actually. Some of you I know, and some of you are new. It's great to meet you. Wish you all the best with your work. If we can help you with Transforming Chaplaincy to kind of strengthen your work, do research about your work, that's what we're here for. And we're very, very happy to do that. So good luck to you all. Thanks for being part of this.
Thanks, everybody. I so appreciate it. And if you want to join us again, next month, we're doing this with Kate Peterman, wonderful researcher, colleague of ours. All right. Take care. Be well, everybody.